Good afternoon, good morning, good evening, wherever you might be in the world, and welcome to this AFREhealth Project Echo, the first in the webinar series. We are very happy to have you on this session. And the title of this webinar is the New Africa Eco Health Professions Education. And we're here to provide you an overview and tell you about what it offers. So welcome to everybody on board, and we're very happy to see you. I'll give you a very brief intro to this, although that is the point of this webinar, is for you to learn more about what Project ECHO is and what it aims to achieve and what it can offer you. So I won't dwell too much on it because that's what you will learn from the presenters that we have lined up today, who are super, and I'm sure they'll be able to share all the information for you. But in brief, the Project ECHO is partnering with the African Forum for Research and Education in Health, AFREhealth, as you know, Stellenbosch University, and the University of KwaZulu-Natal to establish and operate ECHO higher education learning, higher education virtual communities of practice learning hubs. The webinar will introduce you to the Project ECHO and provide an overview of the higher education learning programs. So my name is Moses Simuyemba, and I'm very happy to be one of your facilitators for today. I am based in Zambia with the University of Zambia, in particular the School of Public Health. I'm a public health practitioner. So let me also allow Jennifer, who is my co-facilitator for the day, to also introduce herself before we go into the main sessions for the day.
Good day, good night, good morning to all of you. So excited to be here. Thank you, Moses. My name is Jennifer Clark. I am a physician from the United States. I live in Tulsa, Oklahoma, so in the middle of the US. I work with the University of New Mexico and have the privilege of being on staff at the Project ECHO. I am part of the global team. I see many of my teammates and many of my partners actually on this screen, and very, very excited to be here and to share this responsibility of facilitating this conversation with you, Moses. And so back to you, and we'll get started.
Thank you so much, Jennifer, for introducing yourself. Definitely a very exciting moment for us, and we're happy to spend this 1 to 1.5 hours with you. This is scheduled to be a 90-minute webinar, so we hope you can stick around, and we're glad you could make it. I know you're all very busy in your various duties, so it's always a pleasure when you can make events like this. Just to say that in terms of if you have questions during the presentations, I believe the chat is open. Please feel free to post your questions in the chat. And the presenters, when they're done speaking, will try to address your questions, but will also take note of them for the Q&A sessions that we'll have between the presentations. But otherwise, we have 3 presentations before our first Q&A. So if you have any questions, do put them in the chat and we'll be happy to address them as best we can. So without wasting much of your time, let's get right into the first presentation. I will ask our first speaker, Georgina Yeboah, who is Executive Director at AFREhealth, to firstly introduce herself properly before she gets into her topic, which is AFREhealth and the Project ECHO partnership. Georgina, it's all yours.
Thank you very much, Moses, for the opportunity, and thanks to everyone who is present here today. And I am Georgina Abua, the Executive Director for the African Forum for Research and Education in Health. And I am from 2 backgrounds. I'm a health service administrator, and I'm also a human resource for health practitioner. So I practice both professions as a person. And for today, I'm sharing with you the partnership that AFREhealth has with Project ECHO. And so just permit me to share my slides. As you can see, just having a little hitch, but I will be just on that so that you can see what I'm sharing today. So my presentation is about AFREhealth, why we decided to enter into this partnership, and then what you should expect from this partnership. So that is what we are here to present to you. Just getting a little assistance from Roger, as I'm getting a little technical hitch from here. All right, so just permit me to share as I have it with you. I'm sorry for the hitch, but just bear with me as I share it as it is. It was okay, but we just had a little hitch for that. So to give you a brief about AFREhealth, who we are as an organization, AFREhealth is a Pan-African network representing health professionals and institutions with vast experience. And we were established in 2016. And we are located in Kumasi, Ghana, at the Kwame Nkrumah University of Science and Technology. AFREhealth, all that we are seeking to do is to ensure that we have excellence in health professions, education, research, and service. And we want to do this through the interprofessional practice, hoping that when we all work together as health professionals, we'll be able to meet the health needs of our population in Africa, because Africa has a lot of health challenges, but we know that one profession alone cannot solve that. And it will take all of us health professionals working together for us to be able to achieve that. And where did AFREhealth come from? From 2010 to 2015, there was a PEFA grant funding from the US government that came to Africa. And we had these initiatives, that the Medical Education Partnership Initiative and then the Nursing Education Partnership Initiative. When these projects ended, the leads saw the need for them to come together and form AFREhealth, so that what they intended to achieve, they could really sustain that. That is how AFREhealth came into being. And for now, we can say that we have over 500 individual members from 26 countries in Africa and 46 academic institutional members. from 18 countries across Africa. And our membership spans across the geographical regions and the linguistic regions in Africa. We also have international members who are not Africans who are part of AFREhealth. What activities are we involved in as an organization? We are involved in research, that is health research, also involved in capacity building, interprofessional student exchange. So we still believe that students have a role to play, and so our focus is also on them. And then we also do webinars like we are having. We have annual symposium, and for 2022, we are having it in Harare, Zimbabwe in August, and we invite all of you to register and attend. We also work through technical working groups, which are communities of practice in Africa. Our vision as an organization is to become a responsive and leading African forum in the pursuit of excellence in health, research, education, and service provision. And we are pursuing this. And our mission is to provide Africa leadership for responsive health professions education, training, research, and service delivery through partnership and collaboration, networking, advocacy, resource mobilization, strategic communication, sharing best practices, and building capacity, as well as transformation of responsive health professions education. I've bolded the A, B, F, and H because it has implications for this partnership that we are in. AFREhealth has 4 goals, and for the purpose of this partnership, I would want to emphasize on the 2 and 3 goals that we have. And these are to serve as a platform for knowledge generation, sharing, and learning by building vibrant, relevant, and impactful communities of practice in various areas related to education and research in health and health in Africa. Then the 3rd one is address Africa's human resource for health challenges by promoting contextually relevant and transformative interprofessional health education in African institutions in order to contribute to increasing the numbers and quality of health care professions. AFREhealth also has a 5-year strategic plan spanning from 2022 to 2026. And our first strategic priority is to advance interprofessional health workforce education and research. Under that, our first objective is to design, deliver, and advocate for innovative, high-impact interprofessional health workforce education. And one of the activities that we are pursuing, which is in line with this partnership, is coordinate the usage of digital technologies and innovations for interprofessional education trainings. And it is for these focus that we have, that's our vision, our mission, our strategic plan, that we noted that the mission, the goal, and the model that Project ECHO is for are in line with what we are pursuing. So when we were approached, we decided that we needed to go along with Project ECHO, and especially when both focuses aim at improving human life. So this partnership with Project ECHO is to establish and operate ECHO higher education virtual community of practice learning hubs in health science faculty schools and other health professional training schools in Africa. And I must say that the focus is not only on those who are directly involved in health professions training, like the academics and clinical educators, but the focus is also on administrators and managers. That is an important thing because we all work together to really ensure that we have excellence in health professions education, which will in the end lead to better health outcomes. And so we are hoping that as these people come together to form a network, they will learn from and support one another, and then use the network to also develop resources that will be available to colleagues at health professions, educational institutions. Our geographical focus. For the start, our focus is on South Africa. That's what the partnership is focusing on. And we are piloting with University of KwaZulu-Natal and Stellenbosch University. And what we're hoping to do is that we'll be able to establish the hub in these institutions at the College of Health Sciences and Faculty of Health Sciences, respectively, in these universities. And then when we are able to do that, we'd want to also expand it to the SADC countries and the countries you can see over there. So if you are there, then you know that definitely we will come to you. Then we will also scale it up to the broader African region. And so AFREhealth institutions in these regions should get themselves ready for us to reach out to them. What are the roles of AFREhealth and Project Equal in this partnership? AFREhealth will be closely working together with our pilot institutions so that we can learn lessons from that and then share with our members as they prepare themselves to also get on board this opportunity. And this is what we are doing exactly today as we share some of the good news with you. AFREhealth will be led by Dr. Moses Simuyemba, who is one of our governing council members, and then also a moderator on this webinar. From the hub, piloting hubs like UKZN and then Stellenbosch, we have Professor Marieke de Villiers, who will be also talking, and you hear from her. She will be coordinating for our pilot institutions. Project Equal also will be supporting us, AFREhealth and the pilot institutions, so that we'll be able to set up the hubs and then run them so that we can achieve the purpose for which we've set them up. In conclusion, I would want to express appreciation to GPIGO HW21, because it is through them that we got connected to Project Echo. And then also to our members, I would like to say that this is one of the benefits that members can really get from being part of AFREhealth. And to others who are not members of AFREhealth, would like to say that we have space for you irrespective of your profession, once we can all work together for improved quality of care for our population. Join AFREhealth and let's all move together. Thank you very much. Over to you, Moses.
Thank you so much, Georgina. That's perfect timekeeping from you there. Thanks for that overview. And I'm sure it's given people a taste of what's to come and arouse their curiosity so that they learn more about what this partnership will offer. I did put in the comments, as Georgina was starting to present, that feel free to please introduce yourself in the comments and tell us which organization you're coming from. It would be good to know, and for others who are on the call to also know who is part of this webinar. So please feel free to post questions, but also introduce yourself in the chat. Right now, I will hand over to Jennifer to lead us through the next sessions. Thank you.
Thanks, Moses, and thanks, Georgina. That was a beautiful overview of how our organizations really do have synergy, particularly around this subject. As a physician, but also I'm an educator and administrator, this is the beautiful crossover of ECHO's start. We start, as you'll find out with Dr. Bikinesi here in a few minutes, we started in the realm of clinical healthcare. And we've now found, as you will see shortly, talking to my colleague, Michael Stanton, that echo can be applied to education. And what better way to introduce that to the African continent, but with a combination between those two things and really dedicating the model to healthcare professions, education, and administration. And so I'm very excited to be able to introduce you to my colleagues who will explain the echo model and then go into its use, its current use in clinical care, and then its application to education at all levels. And then most exciting, we'll be able to share with you our partners at Stellenbosch and UKZN on where we're headed with healthcare professions education in Africa as part of the AFREhealth partnership. So without further ado, I have the pleasure of introducing one of my fellow physicians. This is Leonard Bikinesi. Dr. Bikinesi is an infectious disease officer and is known lovingly across the continent as Dr. Echo. He's been a part of our team for a very, very long time. He lives and breathes the model and has understood the value firsthand of these very small, intimate virtual communities of practice where we democratize knowledge and get it to the people that really need it so they can help others that they serve. So without further ado, Leonard, will you please take the show?
Thank you very much, Jen, for that introduction. So I have this huge task of introducing Project Echo, the model, in a very short period of time. I hope I'll be able to do justice to that. So I will introduce, this is an introduction to Project Echo and then experience sharing. So as part of background, first of all, the ECHO is an acronym which stands for Extension for Community Healthcare Outcomes. And right from the onset, you see is that one of the goals or aims of Project ECHO is to move knowledge instead of patients and providers. And this is something that will be said over and over again. This ECHO model was developed in 2006 by Dr. Sanjeev Arora. In fact, he had this idea around 2003, when he saw that some of his patients that he was seeing as an infectious disease specialist managing hepatitis C were not able to access the care that was being given. They had the knowledge, treatment was available, but due to some reasons, such as the distance that patients had to travel, lack of transport or the right transport to use to go to the medical center in Albuquerque, a number of patients ended up presenting late with advanced disease, or at times they were not even able to access this care. So what he initiated was partnering with doctors from rural clinics or underserved communities in the state of New Mexico. He started with 16 rural clinics and 5 prisons, and he was able to join healthcare providers, primary physicians, nurses, with a team in Albuquerque, which was a multidisciplinary team of physicians, psychologists, and others involved in the care and treatment of hepatitis C virus. What he noticed over time is that through these weekly sessions, these primary healthcare physicians in the clinics and nurses ended up becoming experts. But not only experts, they'd acquired skills that were enough for them to care for the patients in their own communities. And when they did a survey, a research looking at all the data of all the patients that had been cared for, they found no difference in terms of the treatment outcomes between patients who were managed through the ECHO model compared to patients who were treated at the medical center. And this was just the beginning of this ECHO model. The principles of ECHO model are hinged on 4 core things, which we call the ABCD, with A being amplification, the use of technology to leverage scarce resources. Like what I'm simply doing right now, we're using technology, we're using Zoom to be able to connect in different locations right now in the world in real time. And this is what the ECHO model uses. It uses video conferencing software to connect various people in different locations. And when these people are connected in what is called a hub and spoke model, then learning and sharing starts to occur. What happens? The second core principle is the sharing of best practices. And this is very important, especially when it comes to reduction of disparity. In a world that continues to evolve in various fields of medicine and others, you notice that best practices are not always happening across the board. And the ECHO model seeks to ensure that best practices are shared amongst all the healthcare providers or all the participants, and everyone is able to comfortably implement these best practices. A very good example is COVID-19. There were so many changes in the treatment guidelines of COVID-19 over the past few years. Through the use of ECHO, those best practices are shared in real time, which makes everyone be able to implement them regardless of where they might be. The third principle of the ECHO model is case-based learning. So the model is designed in such a way that there is a very short didactic presentation, which usually takes 10 to 15 minutes, followed by case-based learning. Why is this important? Adults tend to learn through case-based discussions, not through didactic. So having more time dedicated to case-based discussions improves the learning and the richness of the learning that occurs through these ECHO sessions. And then lastly, the fourth principle has to do with database or monitoring of outcomes. As we continue to have these sessions, one of the core things that you always think about is this making a difference? How can we continuously evaluate all the things that we are providing, the learning that is taking place, the attendance that is taking place? Are we having an impact, or are we reaching the patients that we need to reach with the best practices that we are discussing? So these are the four core principles of the ECHO model. The goal of ECHO is to touch the lives of 1 billion people by 2025. And you see that this is very possible, especially if you take note of the difference between ECHO and the traditional telemedicine. I'll start with the traditional telemedicine. When it comes to telemedicine, this is really a one-on-one interaction between a specialist or an expert with a patient. And this can be done via video conferencing software of their choice. What it means is the patient will be able to be cared for by the specialist or by the experts. When it comes to the ECHO model, however, you see that the experts or the specialists at the hub team are connecting directly to learners at spoke sites. And these learners are healthcare providers. That interaction that takes place ensures that knowledge is moved from the experts to the healthcare providers who can be maybe at a primary healthcare clinic or a primary health center or a district hospital. Due to the consistent, continuous interaction that happens, they will become experts in their right, and they'll be able to acquire skills and knowledge that are enough for them to care for the patients that the experts would also have been able to care for. The difference is the numbers. There will be more people that are going to be touched when it comes to the ECHO model. More and more people are going to learn the skills from the experts, and more people are going to be treated using this ECHO model. So what makes ECHO work? One of the things that makes ECHO work is that we spoke about technology, but that interaction between the experts or the specialists at the hub team and the learners at the spoke sites automatically have a force multiplication effect, whereby knowledge is moved to people who would not normally have had the skills and knowledge to care for such diseases or to be able to manage such problems. As a result, there's task shifting, so there's force multiplication that is happening. But for that to happen, definitely this is all going through under a community of practice. Something like a social network where people are so safe to share and to learn because they've created this network of learning. There's also demonopolizing of knowledge. Just the fact that the hub team of experts are willing to share knowledge, are willing to share their skills with different people in different spoke sites. It demonopolizes knowledge. As a result, especially those people in underserved communities, it increases their joy of work, increases satisfaction, and of course reduces isolation, professional isolation as well. And then one of the most interesting, and this is one of my favorites, the all teach, all learn concept that the ECHO model brings about. Everyone is learning and everyone is teaching when it comes to the ECHO model. One can ask themselves, how are the experts learning? Well, they are learning in this way. Every time they are sharing their recommendation to a case, and every time they are receiving feedback from those POC sites participants on how their recommendations have had an effect on the participants, on the patients, whether it worked, whether there were some modifications or refinements that the team on the ground did. The experts are also learning that way. They're also learning to refine their recommendations based on the feedback that they're getting from the participants. So everyone is learning and everyone is teaching. With that brief, I just now want to showcase just a few slides on the impact that ECHO has had in Namibia. Namibia being the first African country to launch this ECHO model in 2015, and this was an HIV care and treatment ECHO. This was started with the hub in Windhoek, that's where the experts were, and initially there were 10 spoke sites, and these programs were mostly on HIV care and treatment. That's what the beginning of ECHO in Africa and in Namibia. On the screen there, on the slides, you see some of the screenshots of the first session that was launched in Africa. So these programs have expanded now. From 2015, it has expanded not only in terms of the number of spokes, but also the program area that we are discussing. This is just an example of how the spokes have increased. In terms of program areas, we started with the HIV care and treatment. We moved to HIV drug resistance, which is done on every Wednesday, 3 p.m. Central Africa time. We also have COVID-19 echoes that we're running in the last 2 years. And then we're starting a quality improvement echo as well as a pharmaceutical echo. And because of the benefits that ECHO has had, the ministry is expanding to 10 new spoke sites this year. Of interest is these spoke sites are going to be based at correctional facilities. This is just one of the articles that was published looking at the evaluation of this project ECHO in Namibia. Of note is that there was overall improvement in knowledge of HIV, especially amongst the nurses, of about 22.3%, and this was clinically significant. There was also reduction in professional isolation, and there was an improvement in continuous professional development credit access because of this ECHO. In terms of being an HIV care treatment ECHO, viral load suppression, and these are results that were shown in 2020, where we're looking at viral load suppression by district. And when we look, there are many factors that are, of course, having a bearing in terms of viral load suppression in Namibia. But what was noteworthy is the districts that had ECHO before 2018 tended to have better viral load suppression compared to the ones that started a little bit later. And as a result, the ministry said every district should just have this model in all the clinics and the facilities. This is a snapshot of the 2020 ISQA. This is a quality improvement conference where we evaluated the viral load retention, patient convenience, and the viral load suppression of third line cases that we're discussing. We're looking at the standard consultation with the referrals or patients who were initiated on third line using the ECHO model. What we noticed was there was no difference between cases of patients who were moved to third line HIV drugs versus those we're seeing at a referral hospital. Interestingly, most of these patients that are now being seen using this echo model or initiated on third-line drugs are initiated by nurses. These are two snapshots of papers that were presented 2021, both of them during COVID-19. The one on the left was just highlighting how Namibia adapted HIV treatment programs during COVID-19, maintaining care. And one of the key things we used was the use of echo model, not only to continuously provide recommendations in care and treatment, but also to ensure continuity of care by coming up with home delivery methods, going to the borders, and ensuring that there is continuity of care. The one on the right really went into detail about how echo was used to maintain services, especially between the Namibian and Angolan border, where we're having a lot of patients with a high risk of having poor retention or having defaulting due to COVID-19 because of the restrictions in movement. Using echo, we're able to reach out to community-based healthcare workers at the border. We're able to connect with them and ensure that treatment of our patients that were coming across the border continued without any disruption. So these are just a few snapshots of the benefits and the impact that echo has had in Namibia. And I really agree with what Margaret Mead said. You never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's only the thing that ever has. And with AFREhealth coming on board, no doubt that that small group of people would definitely make a difference. Thank you.
Oh my gosh, thank you, Leonard. You couldn't have said that much better. You know, that quote really resonates for those of us who've had the pleasure of being able to be involved in these virtual communities of practice through the ECHO model. It is that small, intimate group of people that are committed to each other, not only to make the world better for themselves, but also the people that they serve, and they do it in team, know that they're in community. And it's a beautiful example of what has been done with the model in Namibia to help those who are living with HIV. And what I'm so excited to do now is actually to hand over the presentation to Dr. Michael Stanton, who is he has a PhD in education and adult learning and organizational development, and he serves as our director for ECHO for Education at the Institute in Albuquerque. And what Leonard has beautifully shown in clinical care, I'm going to hand over to Mike to talk about how that's being adapted to education, and particularly this beautiful synergy between education and healthcare professions. And so without further ado, Mike, I hand it over to you.
Thank you, Jennifer. And can everybody see my slides? Great. Thank you for that warm introduction. And ladies and gentlemen, this is a very much an honor for me to be with you this morning here in Albuquerque and this afternoon where you are. Thank you for allowing me to be with you. I also would like to introduce two of my important colleagues in this work. I lead really a team that is focused on, as Dr. Bikinesi mentioned, running hub as a super hub for education programs here in New Mexico, where we are designing and running 22 different programs supporting early childhood, birth to 6, and also what we call primary and secondary education, as well as adult education. Dr. Edward Harris will be here shortly to help me answer questions. And also Christina Kudermair is one of our program managers to support our global education movement and help work with you and others possibly down the road. I'd like to begin with an important, just as Dr. Bikinesi finished with that really important Margaret Mead saying, we believe here in Project ECHO and ECHO for Education that education is the engine of justice, and it has the power to reduce poverty excuse me, improve health, solve climate change, strengthen economies, and combat racial inequities. I was inspired to this, and this is our inspiration every day here at Project ECHO. But I was inspired by Dr. Aurora as I heard his presentation, much like Dr. Bikinesi's back in 2017. And since then, I've been had the honor to work with him as one and provide and build one of the first ECHO for Education programs in the world, transposing the medical clinical ECHO model into the education space. And I'd like in the minutes ahead to be able to share some of the key elements of ECHO for education that we'd like to continue to discuss with you and help support you. So one of the important kind of lighthouse areas for us that drives our work in the global movement is the United Nations Economic and Social Affairs Sustainable Development Goal. And as many of you may know, goal number 4 is the focus on quality education. And that's where we include that inclusive and equitable education. And you'll see the term equitable access, reducing disparities at the core of ECHO for Education and ECHO for Health and Medicine. And it really recognizes the need to provide quality education. And for this discussion, I'd like to work with you with the idea that it's not only in what we think of education for primary and secondary school students, but think of this as your students providing a change and an opportunity in our practice and I've been a professor of education here at the University of New Mexico, so that we can provide quality education for all, not just children, but our adult learners as well. One of the elements that we have in the education space, as we transpose the medical clinical model that Leonard described, is really kind of analyzing what does ECHO do that works in the education space and for education. Because we know that we have professional teachers in primary and secondary, but we also have very strong professional medical instructors and professors. And everybody is committed to their student success. But not many of our instructors, and it's all over the world, folks, here in New Mexico at the University of New Mexico, Jennifer has shared at Oklahoma State University and my colleague at Harris, but not many of us as instructors in higher ed are demonstrably really using the evidence-based practices to teach. So we have those evidence-based practices in terms of knowledge, but being able to transpose that knowledge into practice through our teaching, effective teaching, is not always there. We have rigorous studies with large effect sizes in the areas of significant student success. There's great pockets of excellence and specialists and specialization for adult learners. Yet many of these practices are not really making it into our practice of teaching and instruction. So we see ECHO is really solving that challenge for education, a method of translating research into practice. Let me get caught up on my slides here. So how do we translate research into practice? Well, first, we learn something new as adult learners and construct an understanding of the facts through lectures, didactics, courses and classes, workshops, continuing education opportunities. In the ECHO model, this is that 20-minute didactic that Leonard just described for you. And that's what we call the learning portion of ECHO education sessions as well. Number 2, we consciously translate new knowledge into procedural rules for action. In the ECHO model, this is the key component of the session. And this is that all teach, all learn that Leonard latches onto. And Leonard, I'm absolutely with you. Our experience in 5 years of programs is for our educators, that is the real sweet spot, the real area of importance for our participants in education. So we translate knowledge into procedural rules for action in this step. In the ECHO model, this is the key component of the session, where participants share their knowledge. Excuse me, I'm getting some interruptions here. They're sharing their knowledge, and for example, a leadership echo, for example, college and university leadership echo could be a topic, could be problem-solving ideas that pertain to leading a group of learners or instructors or professors in your college. Or in the case of an instructional development, for example, many of you, like Jennifer, are practitioners as well as teachers in schools of medicine. The case could be ideas that can be applied in your classroom to your students. These are cases, what we learned early on is cases in education were not necessarily focused on individual patients or cases. More importantly, and what's really been an area of effectiveness is our cases in education echo sessions discuss complex situations for real-time advice from experts, situations that they're finding in the practice of instruction or teaching or building a new program. And in a community of practice, where a group meets frequently and develops, number 3, they develop trust in each other in that community of practice, such as the ECHO program. Participants receive constant feedback and support for the implementation of best practices in their work until it becomes automatic. Again, as we get in front of our students, young and old, being able to stand in front and just automatically know how to bring up a particular process or procedure for effective adult learning is what ECHO for education programs will help participants get to. So this is how ECHO translates research into practice. Now I'd like to take a look at why we use the ECHO model for education. So as Dr. Bikinesi mentioned, all teach, all learn is very, very important in this next step. We build capacity by creating these virtual communities of practice, and these is where we translate that research into practice in that hub and spoke model. So our spokes, our participants, are actually instructors within one or across several universities. I notice many of you are from universities all across the continent and are able to now come together, if you could imagine this, as not just in clinicians discussing practices in your clinic or in your practice, but also now discussing opportunities to learn and improve your teaching and learning opportunities in your classrooms for future medical students and nurses. So, for example, we learn new practices to deliver in ECHO in the same type of timely, relevant, and accessible instruction for improving teaching and learning in these colleges and university classrooms. And it allows the time and space for the participants to share their problems of practice and create solutions together so that they can go back into the classroom and become more effective. And as Dr. Bikinesi mentioned, this is how we as adults learn best. And it allows leadership in colleges and universities, like many of you here today. You could receive new knowledge and skills and effective leadership that supports good teaching and learning in your classrooms and your colleges. Participants in the Leadership ECHO for education programs share their complex challenges that they face and the barriers, and then together they create solutions through the collective problem solving. I'm going to move more quickly. You saw this hub and spoke model that Dr. Bikinesi mentioned. So this is just a summary that I'd like to share with you, and it gives another visualization where we work together. Again, originally this was designed for our early childhood and primary and secondary educators, but it has the same kind of effect of thinking of education professionals impacting their students and impacting their communities. So participants in ECHO for Education programs have this kind of effect of not just impacting those participants, those college professors and instructors, but go far beyond that. And this is described in what you saw earlier in the term force multiplication. And we see that happening in schools and colleges where we equip the participants who join us in our ECHO session with the knowledge and practices and the ability to become autonomous learners. We help increase and enhance the strengths that they already bring to the learning community, because each of us as participants in education have expertise. We're in the classroom or we're in the college room of study. But now being able to have, just as you saw, impacting a number of students, we also know that when participants in our ECHO education programs come, they're sharing their best ideas in the lunchroom, in their community of local community, professional learning community. And that's where we go to build capacity, much as you heard in our first presentation about the goals of AFREhealth. And just as in the clinical ECHO impact, ECHO education programs can cover a number of different subjects. These are just a few of how they're being used in ECHO programs here in the US and also in India. Here are some of the examples, mainly in early childhood. In higher education, some organizations are using the ECHO model for leadership skills and instructional learning in communities of practice. So organizations can use the ECHO model to complement already existing instructional courses by creating that community of practice where participants can present their implementation of best practices and receive feedback. So much like Dr. Bikinesi finished, I'd like to share this quote with you and then a couple quick information slides. Our research, we don't have research yet out of our center here at the University of New Mexico of impact on students, but we do have a lot of good research and anecdotal evidence, but also scientific research that shows that participating teachers and educators in ECHO sessions do improve their practice and their knowledge and efficacy. But we also get quotes like this, that ECHO is the best professional development out there for teachers, for educators. It is being developed by educators who genuinely have a passion for their profession and intended for educators who share that passion. ECHO is an opportunity that is not to be missed. So again, think of this as ECHO for our education team, much like Jennifer and the team that's supporting many of you in the health and medicine, to help you consider and support your ideas for local solutions for your challenges in your classrooms of instruction. If you would like to pursue this in more detail, let our global education team really arrange meetings with you following this. My colleague, Christina Kudermair, is with us. She can answer questions through chat. We'll be here all throughout the rest of the webinar. You can observe an ECHO for Education session and really consider attending our introduction for ECHO that goes into more detail as I described today. Here's our contact information. I know you'll be getting the slides, and we look forward to hearing from you. And thank you again for this time.
Thanks so much, Mike. I really appreciate those comments, and hopefully you all are getting a flavor now of what the ECHO model is and creating these virtual communities of practice, really taking knowledge and distilling it down into actionable items. And so we just want to pause, Moses and I, for a few minutes and just take some questions on the ECHO model. I've seen a couple in chat, and I don't know, Moses, if you have some others, but we'll just kind of walk through the ones I see, and then you tell me if there's any others, and then we'll move on after we've had a few minutes to kind of address those. Leonard, I know that you probably have this firsthand living on continent, but I know that working with partners, we deal with this issue of technology, particularly around bandwidth and connectivity. particularly during heat and electricity issues and things like that. Can you speak to, kind of what is the technology that underpins the model and how we've overcome some of those hurdles?
Yeah, thanks, Jen. So in terms of some of the technology that is being used, of course, there's a lot of video conferencing software and equipment that the teams have to purchase and procure when they're setting up these hubs and spokes. And this equipment depends on the size of the room, the number of participants that are going to be there. That's the first one. And the other part of technology use is in terms of the monitoring part of it. There's web-based software that is designed specifically to help with evaluating the eco programs. When it comes to its use in Africa, for example, I don't have much experience in terms of electrical challenges like the ones. I know there's load shedding in South Africa. But I also know that there's a successful running cancer echo in South Africa. That is at formerly Kimberley Hospital. They've been running a very successful cancer echo since 2016. And they've been able to not only reach out to a number of spokes sites in South Africa, but also some spokes outside South Africa, like in Mozambique, Zambia, and others as well. What I've heard from my colleagues in Africa talking about some of the challenges in terms of internet connectivity, as well as use of electricity. In Zimbabwe, they spoke about the use of solar. They were there to procure some solar panels for eco sites in the rural areas. What they're doing, especially here in Namibia, we don't have a problem with electricity. With very few areas with no internet connectivity, but those few places, what the team does is that all the sessions are recorded, and they're using those recorded echo sessions to then play or to send to those facilities or clinics where they don't have internet connectivity, and they're able to watch, they're able to follow along the discussion, and if they have questions, they then use WhatsApp or any other means to connect with the rest of the team or the experts. Thank you.
Thanks, Leonard. A couple of other questions. One that's really interesting, and I'll try to address, and then I'll hand a couple over to Mike and his team. Kind of is a great question about this whole relationship between telementoring and telehealth. So simply, this is not a replacement. The way we want you to start thinking about ECHO is that many healthcare facilities and education systems are developing digital platforms or digital processes by which complements the traditional learning pathways. And so telementoring actually complements telemedicine. It really is that time and space for that really intimate conversation between practitioners, whether education practitioners or medical practitioners, to talk about their problems of practice so that when they enter into telemedicine, it becomes a much more facilitated and rich, meaningful kind of opportunity to care for people. And so oftentimes they actually co-locate together. So a group of practitioners will develop an ECHO, let's say around HIV, like Dr. Bikinesi's talked about, and then they'll go on to actually deliver telemedicine, and then they actually come back and talk about that experience in their ECHO. So that's the complementary side by side. It's an addition to, it's a new kind of way to think of digital health, particularly in digital education. And so it's a, kind of rounds out your, kind of offerings, if you will, in that realm. Mike, one of the things that, that one of the questions that got asked is, translating research into practice. There's a question about, kind of this issue of culture factoring into that translation. So can you talk about that a little bit?
Thank you. Very good question. That has been an important focus in my practice and experience over the last 5 years. We have to face those kinds of issues of current practices and culture and points of view. So we've really thought of it as a pilot, thinking of a small, successful pilot in a program with those risk takers, with those first, folks that have a passion to improve their practice, study it, research, look at the effectiveness, and then share it with those leaders who really are at the core of those cultures. And it takes time, but we found over the last 5 years here in a smaller experience here in New Mexico, we've really had a great opportunity, excuse me, from that first pilot with 30 educators to a meeting yesterday with one of our deputy secretaries of education for the state, discussing as a full partner of ways to help change culture in our partnership.
Thanks, Mike. Yeah, it's an issue that we face across all, and actually it's one of the places that I think ECHO has serves is to have those, kind of conversations in that bubble of trust to kind of say, how are you facing this? And many of our ECHOs are multidisciplinary. As you guys can see, we've got educators, clinicians and administrators here today. And so really being able to invoke that empathy and compassion and be able to see a problem and, kind of problem solve together. And so ECHO has contributed that and able to overcome some of those cultural norms in its kind of its practice. And so really appreciate that. Moses, I know that there are several other questions. Are there any ones that you've seen that we need to address before moving on to the panel?
Yes, Jennifer, I think it's because it's related to what you talked about earlier about telemedicine, telementoring versus this model. There was a question about artificial intelligence and where it fits in all this. So I think that's maybe one we could address now. Just to say, if your question is not addressed now, there is another Q&A later, so we will cover that. Don't worry. Yeah.
I'll just add, kind of add a couple of things, and then we'll move on to our panel discussion. I think it's evident that ECHO really fosters human-to-human connection. Artificial intelligence, particularly at the bedside, is wildly beneficial. We know so much about sepsis care, particularly, and the use of artificial intelligence in identifying those cases further up front. But we find that much of the issues that people have in their practice actually is about human-to-human connection, whether it's human-to-human connection with our colleagues, our administrators, or our patients. ECHO is really dedicated to taking tools like artificial intelligence and saying, how best can we use it to benefit each other as we connect in caring for and making our lives better? So I already see an ECHO coming up, an ECHO for artificial intelligence, kind of, and how humans kind of can gather and decide how artificial intelligence actually benefits us without causing the controversial harm that oftentimes comes with it. So, kind of our effort is really dedicated to fostering those human-to-human communications. So hopefully that directly answers your question. If not, please chat in and we'll answer it in our next Q&A. Thanks for those comments, Moses. Looking at our time and really wanting to allow the stars of our ECHO to shine today, I have the privilege of introducing you the team that will be launching this new ECHO. As Georgina said previously, AFREhealth is partnering with UKZN and Stellenbosch University to deliver the first pilot program, an ECHO for healthcare education professionals, and particularly around administration. And so I have with us today, Dr. Petra. Dr. Petra, I'm going to totally get your name wrong, I'm sure, but it's Bryzovitz. And she is a nurse by background and is part of the UKZN faculty. We also have Fatima Suleiman, who's she's a physician or a pharmacist with her doctorate and is at UKZN as well. And then we also have Dr. Marieke de Villiers from Stellenbosch University, who will be here with the AFREhealth team to round out a panel and discuss their experience about thinking about the ECHO model within healthcare professions education, everything from the classroom all the way up to kind of the provost and the president's office, and what that looks like so that we can spread this model and its use across the practice of education. So with that, I will turn it over to Marieke, Fatima, and Petra to really talk about this experience. Thank you all.
Jennifer. I just want to check if you can hear me well. Yes.
Loud and clear.
Okay. So good morning, good afternoon, everybody. Fatima, Petra, and myself would like to give you a little bit of a taster for what this ECHO will be like and what is it going to cater for. So we are calling it Africa ECHO Network for Health Professions Education. And Dr. Olaleye from Ibadan asked the question in the chat, is it only for doctors and nurses? And the answer is an emphatic no. We talk about health professions education, and AFREhealth as such, and this ECHO has an emphasis on interprofessional learning and training. So we really want all health professions to learn and train together. So the partners, as Georgina has already laid out, is the University of KwaZulu-Natal, where Fatima and Petra are the principal investigators, and then Stellenbosch University, where Professor Ian Cooper is the principal investigator. He will join us soon. Myself, I'm also from Stellenbosch University. I'm the project coordinator, and then we work together with AFREhealth, where Moses is the coordinator and Georgina the CEO. So, and then we all work with ECHO together. So you can see it's really a powerful, powerful in its diversity partnership, and we're looking forward really to see what will come out of it. So I will do a few slides and then I'll hand over to Fatima. Fatima, if you can move on to the next slide. So why this topic that we chose? And I haven't unveiled the topic. We'll keep you in a little bit in suspense. So we have looked at, you know, what can this ECHO in health professions education in Africa really do? And we started brainstorming, and we said that the COVID-19 pandemic severely impacted on health professions education, requiring drastic changes. And all of you will know you had to stop teaching your students, you had to go online, you had to do all sorts of things, which severely disrupted a lot of things. But it's not the only thing that can disrupt what we are doing. Boycotts, unrest, natural disasters, protest, and war, like in the Ukraine now, will continue to impact health professions education institutions and training programs. So this poses challenges and tensions for staff at higher education institutions, and particularly we're focusing on those who train health professionals. So they're educators in health professions. So this raises questions of what do we espouse in HPE? What are our principles, support, and intentions? So what matters most in what we do? What are the educators hoping for in learners? And then the third question, which is where we homed in, what opportunities are there for educators in times of disruption and change? So what we then, okay, let me talk about the response and then I'll talk about the topic. So there has been an amazing response. It is just amazing to see the resilience and the innovation that humankind has to respond to challenges. So many faculty have acquired skills in coping, professional and personal, helping both colleagues and students to cope. Resources were developed to help prepare to manage ongoing disruptions. So we are thinking that while also addressing the current needs of learning needs of the staff, we can tap into the wealth of experience that has been developed over the last 2 years. So we are not saying that we are the specialist and we know everything. We really want to mine for what is there in the community of health professions educators, so that we can share it. And what is this, what Leonard and Dr. Stanton talk about, the amplification effect. So what we're hoping to create is a shifting space, trying to integrate life and professional experiences and knowledge. And from that, hear how people have managed disruptions in health professions education, good practice, poor practice, what works, what not. and in that then form a community of practice towards a way forward in being prepared for future disruptions. So I'm going to give over to Fatima now. Thank you.
So what we aim to do in this particular ECHO project is to look at how we can facilitate discussions with staff at higher education institutions, specifically those that train healthcare professionals, and look at how we can put together sort of best practice in how we manage personal and professional coping and well-being strategies in a disruptive environment. But it's also, COVID's also shown us that we've become very isolated as academics as well. And it's necessary to form a community of practice of professional trainers, not just to share practices, stories and learning events, but maybe also to be able to create a group in which mental well-being can also be an objective. We would also like to look at developing learning scenarios and best practices that cover the challenges brought about by the health professional education disruptions. And remember, in KZN, we've also had the floods as a disruptive, which is also what we talked about, the natural disasters as well. So critically, it's becoming more and more important that we actually do look at how resilient academic institutions are when these events are brought about. So I'm trying to think whether I'm ahead or not because I can't see. So basically, we're looking at all healthcare or higher education institution personnel that are involved in training healthcare professionals. And it's not just the academics, it's the support personnel, it's the clinical training people, everybody who is actually involved in the training setup and that. Whoever's interested in joining us, who are looking at exploring possibilities in dealing with disruptions and looking at innovative ways in which to manage this, we welcome everyone, whether you're new to academia or whether you're an experienced academic or support staff or training personnel within the institution. And as Mariki mentioned before, it's from all discipline. We are definitely looking at an interprofessional focus because health professional education is beyond nursing and medical education as well. Georgina mentioned that the initial focus will be South Africa because that's where the 2 pilot hubs are, but we will be working with AFREhealth to expand this throughout Africa. So if you're not in South Africa but would like to be with us or work with us, please let us know. We're happy to include you in our pilot rollout programs. So what can you gain by participating with us in this particular ECHO project? Well, a lot of us, as Mariki mentioned, have learned things and have learned to cope. And what better way than to actually bring together these practices and make sure that other people are dealing with it if you've learned to deal with it well, or if you haven't managed to cope, to learn from other people about how to cope. So to use this as a learning opportunity to share everything, best worst practices, reflections, case studies, policies, programs, standard operating procedures, to share all of that in that. We've had a lot of uncertainty and stress. There's a lot of stuff coping with working from home, being at home, handling disruptions, especially female academics as well. So how do we manage all of these issues in this environment? And we'll talk about that. We will think about how to strategize and how to plan to continue with teaching and research despite disruptions. And this could be also student unrest issues as well. And the nice part about this is that we will draw on support and expertise from colleagues across the country so that we all understand that we've shared the same experiences and that we can come up with solutions together. And in the end, develop a community of practice and not feel so isolated during these events. I will now hand over to Petra to complete the slide presentation.
Thanks, Fatima. So how will we reach these participants that we want to include in our project? The first thing that we will do is to invite participation through our deans committees. Our university deans have various opportunities where they meet, and that will be an excellent place for us to initiate contact. We will also use sort of national professional forums. We have a group of health educators who meet. There's actually a conference coming up and we will be presenting a workshop just to introduce our idea. We will be sending letters of invitations to the various deans, and also obviously making use of all our professional contacts in the various health professions. And we really see sort of snowballing as being the way in which we will be effective in recruiting our participants. Thank you, Fatima. So how will we measure the success? I think one of the major ways will really be in terms of attendance, having a look at the numbers of participants from different higher education institutions. And obviously, we also want to really be sure to work on a spread of professional groups. We will have a look at the participation of the participants, looking at the kind of questions that they're asking, the various themes that emerge from these discussions. We will be measuring satisfaction. And as Fatima mentioned earlier, and Mariki, we want to develop at least one virtual community of practice. In our work, we will be developing case studies, and another resource that we hope to establish is a database or a repository of information for our participants. Thank you. So obviously we don't expect this to be particularly easy. We know that there are going to be a number of challenges. And I think one of our major challenge will be around recruiting. And I think we'll have to work quite hard and quite strategically in order to ensure that we do get a spread of health professionals and higher education institutions, throughout South Africa. One of the major problems I think we'll have is COVID-19 fatigue. I know in terms of my own colleagues that I associate with regularly, as soon as someone mentions COVID-19 nowadays, you see people's eyes glaze over and they really don't want to talk about it anymore. 2 years has been quite enough. So I think we will have to consider how we're going to manage that. The time commitment, the people we are targeting are extremely busy people, so that will be a challenge. And I think it's I'm sure the same with all hubs that are starting out. It's about gaining momentum and then making sure that you can maintain that kind of energy moving forward so that you keep people engaged and keep people interested in this whole program. We will want to be sure to choose themes that are relevant and appropriate across the spectrum for all the health professionals. And I think another really important aspect, just because of what we will be discussing, will be making sure that we create this safe environment where our participants feel comfortable, feel safe enough to be able to open up and discuss with us. And again, we will have to work hard to identify people who would be willing to present their challenges to enable us to use these as our case examples. So I think that's all, Fatima. Yeah, so we are open for any discussions or any questions, and thank you for your time.
Oh my gosh, thank you, Petra, Fatima, and Mariki. That's a perfect example of how people are starting to take this idea of the model, really developing this concept of telementoring, whatever subject it is that you're wanting to create this virtual community of practice around. One thing I really want to highlight before we get into a couple of questions is this idea that Fatima had raised about well-being. One of the things that we are facing is, COVID-19 is one of many things, as Mariki say, that, that is disrupting our ability to teach, to educate. And what we found is that when you have these early adopters, these people that are willing to create the time and space, and that's all. Every hub is always worried about that. Are there going to be people that want to do this? I can definitely say yes, but it's always that scary step, that inertia that you have to kind of overcome. That once you get started, people find this place where they have agency, And that's what virtual communities of practice allow, is this idea that they can affect change, which then builds resiliency, that when time does come, that they can maintain a state of well-being despite adversity. And so I really wanted to call kind of all three of your comments out with regards to that, and how ECHO really does create a bubble of trust, as Petra said, so that people can feel empowered to make the difficult changes and move things forward. So really, thank you for sharing your experience. We're really excited to see the launch of this first pilot program. It's likely, as I've already seen through some of the questions and some of your guys' comments, it's going to be the first of many programs that will address different needs, different population, different learners. And so we're excited to see the ball get rolling. So Moses, do you see any questions to ask the panel?
No, Jennifer, no new questions, but we had one which was pending from the previous session, which, although I think this session has actually answered that about, is this restricted to just doctors and nurses? And I believe you adequately answered that. This is very interprofessional, and it's about involving everybody and getting everybody to benefit from what's happening. So other than that, I have not seen any new questions, but we'll give everyone a last chance to ask a question. If you have any questions, we have kept super on time. I believe we have about 10 more minutes. So if there are any other questions, we can have those. Okay, the question is about how do we counter that we are so enthusiastic about this and very positive about it, but obviously there might be some negative aspects to it. So, would anybody, any of the presenters like to answer that? How do we get rid of this or moderate ourselves sort of in terms of this positive bias that we might be portraying?
I think, if I may, Moses, I came from a presentation earlier where we had Professor Sanjeev Arora present on the ECHO model here at UKZN. And everybody was concerned about this issue of sustainability of the hubs, of sustainability of participation and engagement. And he mentioned something that was really very on topic, in the sense that, you're moving knowledge, not people, one. And two, it's about the fact that, if you can get someone to come in and commit to maybe like 4 sessions in a month, and then leave it up to them thereafter to decide how much they need and how much they don't need, you've actually made a difference. Because what you need to know about these ECHO sessions is, it's about the fact that you're sharing knowledge, you're sharing best practices, you providing solutions, and people may feel they need a solution and they've gotten the solution and they move on, and then they come back either when they have a case or a problem, and other people engage and come into the fora, and that way you actually have a larger impact and a more exponential impact. So the issue about the positive and the negative is the fact that I think that people will come, take what they need, go back and implement, and come back when they need to. And then what might happen as well is there's a lot of this kind of peer support. So you might have people initially who come into this engagement that feel this is not for them, or they might be shy to share, or they might not find what they need. But by being in a group, they actually then have a group with which they can discuss this with and find other avenues to get what they need. And I think that's what's so special about this ECHO model, is that it's creating these local communities and these local support groups, aside from the bigger project as well. So I'll stop there in case somebody else has something to say, because Leonard and Michael might have more experience.
Yes, thank you for that, Fatima. I think another thing that you've sort of alluded to in terms of asking Leonard and Michael, I think, is triangulation. So Leonard gave us a very good example of that. They had data that showed that what they were doing was having an impact. So I think that's one very good way as well to get rid of such biases, to triangulate between different data sources and actually see the impact of what you're doing. But I'll let them answer in case they have that. Michael, you have something to add? Please go ahead.
One thing that really has carried us through and has really grown, and I see it really happening more in the adult learning space as well, is that area called joy of work, right? That is mentioned as an important part of ECHO programs. We have really seen this in working with educators because of the challenges that they face, the isolation, the ability to have to dealing with, as so many of you are, many of the same challenges of COVID and all of these other barriers to success in their lives as well as their practices. So we really, that extra is kind of the secret sauce, that ability of building that community of practice. And my research in adult learning theory in my doctorate program was really kind of bringing that out and studying what are the, where does that joy of work, or what impact does that have when people are within a community of practice with like-minded peers. They're all grappling around the same issues and challenges, whether it be medically or in the education classroom. When that happens, that's the magic. And then having that base for knowledge and that base of collaborative problem solving really becomes even better.
Thanks, Mike. Yeah, I definitely want to, no pun here, echo that. That, kind of really that really protected environment, being able to, kind of speak with each other. It's that, I love that idea. It's a secret sauce. Speaking of secret sauces, we've had Dr. Ian Cooper was able to finally join us from Stellenbosch. Ian, if you have 2 seconds, I know he works with Marieke, Fatima, and Petra on lifting this big project off the ground in partnership with AFREhealth. Ian, do you have a few minutes or a few comments to make? I see you.
Yeah, you're lucky I can't see myself, but anyway, that's good. Good afternoon, everybody, and sorry I couldn't be with you earlier. I had a pre-existing educational commitment I couldn't get out of. I think the team did a great job. I don't have anything much to add. The only thing I would say in terms of the positive enthusiasm and dealing with that, what we did in a project last year in terms of evaluation was following people up who'd participated 6 months or so after their participation had finished. And to see what have they applied from what they've learned, and what do they remember. Sometimes people can't even remember participating in something. So yeah, it's maybe to get some distal feedback in terms of how long lasting effects are.
Thanks, Ian. Yeah, I really appreciate that comment. One thing I'm just going to say real quick before I add to that is that the team at AFREhealth has put a survey in the chat for you all to fill out as we close our last few comments. So if you would please, to that point, we need feedback to know kind of what you all are needing. So please fill out the survey. To add to your comment, Ian, one of the things, and this actually gets to one of the last questions that we have in the chat, is this whole idea of how to perpetuate and continue, because oftentimes when you create a virtual community of practice, you have the project and then it's done and you never come back together. And that's the beauty around the ECHO. To Fatima's point, it can be short-lived around a certain topic, or it could be around a population of learners that together as a community of practice pick lines of topics they want to speak to. A good example is I'm part of Helping the Healers ECHO right now, that we've had self-care for several weeks, we've had mindfulness for several weeks, and this coming few weeks we'll be talking about grief. And so really changing up the subject matter for that set of learners to really discuss within the virtual community of practice. We've seen the impact not only on the joy of work that Mike was talking about, but also the impact on the students that they are actually serving. So those bifold kind of impacts that we're looking at, what's the impact on the learners and their ability to provide service to their learners, and how that's impacting the classroom. So this bifold looking at data is wildly important. Well, I know that we are closing in on our last couple of minutes. Moses, do you have any other comments, or anybody from the panel?
No, nothing from me. Jennifer, thanks for co-facilitating, and I'm excited. This was a wonderful session. I would just like to urge everyone on, if you have any further follow-up or questions, I believe you got an invitation from AFREhealth Secretariat, so you can always follow up by email in case of anything, and I'm sure they'll be happy to respond. We'll be happy to respond to you. So Jennifer, I open the session and I hand over to you to close it.
Well, thank you, Moses. I just, on a note of gratitude, as healthcare professions educator and clinician and administrator, this warms my heart, and I'm very, very excited to be able to share this space with you and to continue the efforts of ECHO, particularly in health professions education. So thank you to the team that was with us today. Thank you for all your time and your intention, and we will hopefully see you in the coming weeks to months as ECHO starts rolling across the AFREhealth and the African continent. Thanks to each and every one of you. Take care and have a wonderful evening, wonderful day, wonderful afternoon.
Bye.
Everybody, bye-bye.